Good morning, colleagues. I think we're all good to go. Welcome to our session for the Faculty of Community and Health Sciences. Today's presentations are all basically going to be speaking to health and well-being in an era of hyperchange. And we chose that theme particularly because of the major changes and shifts that we went through in the last couple of years. We have some very interesting speakers with very interesting topics lined up for you this morning. So I trust you will sit back, relax, and enjoy each presentation, because each presentation brings something different to the narrative that we're currently working on in terms of the Sustainable Development Goals. So without further ado, the way that we're going to conduct the sessions, I'll be introducing each of the speakers. They will each one have about 15 minutes to present. I'm going to allow some questions and comments immediately after each session so that it's still fresh in your minds, and then we will proceed to the following session. So we'll start off with our first presentation, which will be conducted by Professor Lisa Wegner. I'm just waiting for the bio sketch to be shared. So Professor Wegner is a full professor in the Department of Occupational Therapy. She's at UWC. Her research interests focused on adolescents and youth at risk behavior, resilience, and positive youth development, leisure engagement, as well as leisure boredom, which is quite a new concept for me. A recent research involves the development of relevant community-based programs for vulnerable and marginalized youth, including out-of-school youth as well as rural youth. In 2020, Prof Wegner was awarded a C2 rating with the NRF, making her one of the few South African occupational therapists to hold an NRF research rating. Professor Wegner, over to you.
Thank you, Prof Andipatin, and thank you, colleagues. It's a pleasure to be presenting here today. I'm just going to call up my screen. Okay, I hope you can all see that all right.
Yes, that's all good.
And I'm just going to try and move it on. And now it's not moving on.
Try the arrow keys.
The arrow key down there. Okay, it's popped up now. Okay, is that working?
Yes, that's working.
Okay, cool. So yes, it's wonderful to be here today and have the opportunity to talk to you. I was going to talk to you about partnerships to address occupational engagement among vulnerable youth in South Africa. And I still am going to talk to you about that, but I just want to say that I've changed my presentation, and you'll see why in a minute. So at the opening ceremony of our research week, and some of you may have been there, Prof France was talking to us about how we can make a difference. How does our research make an impact? And how can we work with our students and use what we do, which is knowledge production, knowledge translation, and knowledge utilization, to really make an impact and to link this with the Sustainable Development Goals. Prof France also talked about UNESCO recommending participatory action research towards co-production of knowledge with communities through transdisciplinary research. And that was the word that, or the concept that got me thinking about changing my presentation. Prof France also urged us to be creating a platform for dialogue and promoting ideas for Sustainable Development Goals relevant research. After that, Dr. Mdleleni spoke about a multi-stakeholder approach. So again, the partnership coming in. And he also spoke about an Afrocentric approach to tackling issues on our continent. So with all of that in mind, I decided to change my whole presentation. I always have to remind myself of these different concepts. And so Here it is again looking at multidisciplinary, which is different disciplines working together, but each drawing on their disciplinary knowledge. Interdisciplinary, which is integrating knowledge and methods using a synthesis of approaches. And then transdisciplinary, which is creating a unity of intellectual frameworks beyond the disciplinary perspective. So constructing new knowledge and dissolving the boundaries between the conventional disciplines to construct meaning in the context of real world problems. So this concept really stuck in my head since Monday. When I thought about my own research, the research, and I'm sure for most of us in our faculty, cuts across many of the sustainable development goals, and you'll see them there, the ones that I think my research relates to. But the one that really got me with the whole idea of transdisciplinary research was Goal 17, Partnerships for Goals. And so I asked myself, how do we form partnerships to move towards transdisciplinarity in our faculty? And I am coming this morning with a suggestion, an idea to bridge the gap. This is a research project that I developed last year, in fact, and it's called a community-based participatory action research approach to understand challenges, needs, risk, and engagement amongst vulnerable youth in South Africa. A little bit about the project. I registered it with Senate Research earlier this year, and it does have ethics approval until April 2025. The idea behind the project is to establish a science shop in our faculty. Now, a science shop is a facility often attached to a specific department or a faculty of a university, which provides independent, free, community-based research in response to problems experienced by the community. And this is from the Department of Science and Innovation. So I actually put in for funding. This went through to the NRA for funding. Unfortunately, it didn't get funded, but you know, as academics, we have thick skins. That doesn't put us off. And I thought to myself, how can I use this project to try and work towards transdisciplinarity with researchers in our faculty and students, both undergrad and postgrad, to conduct research in partnerships with community stakeholders. How can we use this science shop idea to work towards transdisciplinarity in terms of the topic of vulnerable youth? Now, you know, in our faculty, we talk a lot about interprofessional education, and we have modules that our students work in. But I think I'm concerned that us as academics are not working enough together in an interprofessional way. And I really think that this is an opportunity for us to start doing this, to work together with our students. So how would this all work? Well, the general idea is that researchers and students will partner with small groups of youths in communities to form science shop research hubs. A science shop research hub, in my mind, would be where our students, both undergrad and masters, I'm thinking master's level, come together, and perhaps once a term, because the terms go by so quickly, we convene a webinar for students, or a science shop webinar for students, staff, and youth. Remember, this is participatory action research, so we bring in youth in the communities that we're working in, and we present our research. This has to develop. We have workshops, but we talk and we look at how we can do research that will meet the needs of youth in our different communities. So I'm thinking for Santa Cruz, Mitchell's Plain, that will emerge as we progress. So this would facilitate discussion of issues and working towards a transdisciplinary perspective. I'm thinking of undergrad students, fourth year level, who I think most of us, our students are doing group research studies. So they would be under the supervision of departmental staff, and then master's students doing individual studies. And perhaps the supervision there could be across disciplines. So I'm going to skip this slide, I think, for the sake of time, but you know that we've got policies and plans. The National Development Plan 2030 talks about building a future for South Africa's youth, strengthening youth service programs, looking at life skills training, etc. We've got our National Youth Policy, which also talks about government partnering with all sections of society and interventions to enable optimal development of young people and enhance their capabilities. We know that youth in South Africa are amongst the most vulnerable in terms of being disadvantaged in the labor market, the high unemployment rates, which are higher than the national average of 34.5%. The most vulnerable are those aged 15 to 24. We've got COVID to contend with, and my colleagues and I have been working in rural areas, which was the presentation I was going to talk to you about today, which shows that youth in rural areas are particularly vulnerable. A little bit about the concept of youth engagement and disengagement. Youth disengagement occurs when young people feel alienated, disconnected, unvalued, unable to contribute in a meaningful way. It's exacerbated by lack of knowledge and skills and structural barriers such as prejudice or limited resources and opportunities that makes them vulnerable. So when I talk about vulnerable youth, I'm thinking youth in rural areas, youth with disabilities, homeless youth, youth using substances, youth involved in gangs. So vulnerable youth. I'm also looking at the concept of resilience, which is the synthesis of an individual's traits, capacities, coping strategies, and processes for positively adapting to adversity and risk in one's context. So how do we work with vulnerable youth to develop resilience in them? So yeah, a little bit more on the problem statement. Young people who engage positively in society are motivated to connect with others and contribute to the well-being of their communities. But we know very well that many youth in South Africa live in adverse circumstances and face many challenges, such as obtaining post-school education and gainful employment. And this leads to youth disengagement. So it's critical to gather information that assists with prioritizing needs and informs the development of relevant programs. How do we develop a transdisciplinary approach to address the issues of youth disengagement and promote resilience, is the research question. The aim of the study is to explore and describe challenges, needs, risk, and engagement in vulnerable youth. And I've added now through a transdisciplinary approach. So there are the objectives of the study. The research approach is going to be community-based, participatory approach. The long-term goal is empowering youth and developing youth-directed programs to facilitate engagement in healthy, positive behavior. It would be a mixed methods approach with a triangulation design involving the concurrent but separate collection and analysis of quantitative and qualitative data. The study setting is low socioeconomic and socially disorganized and or rural areas in the Western Cape, possibly later on in the Eastern Cape and in Mpumalanga. I've got plans for that, but it depends on funding, of course. We would use purposive convenience sampling with snowballing. It's not easy to access youth. We would work with youth aged 18 to 35 residing in the identified communities. But you know, it's really, from past experience, not easy to find these youth. That's why we'd use snowballing. We would recruit youth through our community partners, and we would liaise with community organizations in the different sites, and they would use their networks to invite youth to take part in the study. The sampling frame includes youth who present at the identified community halls or wherever we do our data collection on the specific days the researchers are there to conduct the study. Youth who meet the criteria will be fully informed about the study and invited to participate by giving written consent. The data gathering methods would be a questionnaire, quantitative questionnaire, a needs ranking activity by card sorting, and focus group discussions. The quantitative questionnaire takes about 45 minutes to administer. It's a self-report questionnaire. We've used it before. It's about 141, well, it is 141 questions, demographic information, substance use, sexual behavior, use and experience of leisure time, mental health, and self-leadership and self-management. We would use a needs ranking activity. This is something it's quite exciting. We've used it in rural areas, and researchers with youth discuss possible needs in the context. So some examples of needs would be skills development, further education, housing, health resources, career development and training, parenting skills, leisure and recreation resources, entrepreneurship, and we can add others depending on who the youth are that we're working with. And we ask the question, if you were the mayor, how would you prioritize these needs for youth living in this community? We break the youth up into small groups of around 5 participants, and we ask them to rank their needs from most important to least important. And the youth then walk around and they compare their list with other groups' lists. And this creates really lively debate and lots of discussion amongst the youth. And we then take them into a focus group activity. This is a semi-structured format. And those are some of the questions that we could ask. It's semi-structured, so these can change a little bit, but we delve further into what are the needs, the challenges, the risk amongst youth. And of course, we've got the needs ranking activity that feeds into this activity. So it works really well. Thematic analysis, descriptive statistics, the students, remember that's the students that are carrying out this research. They write up their research reports. Next year, our 4th year students are going to be doing this. We're hoping that they will draft a manuscript instead of writing a full research report. Our master's students complete their theses, they write an article, and ultimately us as staff conduct qualitative meta-analysis on similar research reports of undergraduate students. So we group them according to similarity, and then we conduct a meta-analysis. And remember then that we also have got the monthly seminars, which are the science shop. This is the science shop concept. So we can do this face-to-face or online, but we get our students together across the different disciplines, and we try and work towards this transdisciplinary perspective of addressing the issue of vulnerable youth.
And you have 1 minute left.
Okay.
You have 1 minute.
Okay, thanks, Prof Andipatin. And then, of course, hopefully we're going to get publications in partnership with our students. So it's capacity building with our students and with the youth that we're working with. So the next step, this is my final slide. I've got already 2 master students working on this year. And next year, I hope to have some more students. I've talked with colleagues in SRES who are interested in being involved. Now we have to make it happen. So I'm thinking, if you're interested, if this is something that's tickling your fancy, email me. Let's start working together in a transdisciplinary way. Let's use the science shop concept. Let's see how this is going to unfold. I've got no idea how it's going to work, but let's just see. Email me. We're going to have a planning meeting in November, and then we start seeing how we can make this work in January next year. So there's just a slide on partnerships, everybody that should be involved in a multi-systemic approach, vulnerable youth in the middle. And that's it. Thank you very much.
Thank you, Prof Wegner. Sure, that was interesting. Well done to you for having changed your presentation in such a short space of time. But it's such an interesting concept, the science shop. We all understand participatory action research, but I think when it comes to the implementation, I think a lot of us get stuck because it's not easy. It's not easy to engage in work with communities. Often things never work out in practice like on paper. But colleagues, this was really, really very interesting and very provocative. And Professor Wegner has opened up the door for you guys to contact her should you be interested, because it's a real opportunity to promote transdisciplinarity and for us as academics to really get together and start putting our heads together and looking at what we can do to, address some of the grand challenges. I'm just going to check in the chat if there's anything. Are there any questions, colleagues? Any comments? Anything from your side you'd like to raise?
Chair, there's a comment in the Q&A box.
Okay. Let me just go down there. I'm not seeing anything here, Melody.
I'm seeing it, Prof Andipatin.
Okay, what is it? What was it?
It's from Prof Rhoda. She's
Yes.
saying, could the science shops be integrated into our current community outreach activities that happen on a regular basis?
Yeah.
And my answer is yes, most definitely. So, I'm imagining that perhaps we go out and we're working in wherever we're doing the community outreach, but we work with the youth there, and we then talk to them about what we're doing, and we get their involvement, because it's youth from 18 to 34. It covers quite a lot of people, young people, and I really think that they would enjoy the activity. So, for instance, we could do the needs ranking activity with them. And so I always believe in a win-win situation. We're involving the youth in our communities. They are sharing their issues and their needs, but at the same time, we get them to, we tell them it's part of a research project and we're working with them. We've got the ethics approval and they sign a consent form, and we then can use what gets discussed within our own research. So that's how I envision this might happen, Prof Rhoda, as part of the community outreach days. Genadendal, Krubo, Mitchell's Plain, Versantacral, wherever we go. And we involve our students in that.
And I suppose, Prof, it also speaks to knowledge translation, because you're directly involved with the people that are affected and part of your research as well. So I just love the concept.
Yes, yes, yeah.
Yeah. Colleagues, it doesn't seem as if there's any other questions in the Q&A. So Prof Wegner, thank you so much for that. And to Prof Rhoda, I guess it's something we can talk about in our faculty and look at how we actively implement the suggestion that you're bringing to the table.
Thank you.
Yeah,
Thanks.
Thank you so much. It was really, really good. Colleagues, we can move on now to our next presentation with Prof Chips. Prof Chips is a professor in nursing at UWC. She has recently assumed the newly created research chair in person-centered digital health at UWC, after previously serving as the director of the School of Nursing and the division head responsible for research and internationalization in the school. Before joining UWC, Prof Chips held positions at University of Sydney in Australia, New Zealand, HRC in New Zealand, NSW, Department of Health, and in UKZN, South Africa. She's passionate about systematic reviews, mental health, and particularly digital health, and holds a PhD in telepsychiatry from the University of KwaZulu-Natal in South Africa. She has served on the International Council of Nurses, Telenursing Working Group, the National Department of Health Working Group on Forensic Telepsychiatry, and participated in a Brochure Foundation workshop in Geneva on the ethical issues in image-based mental health. Welcome, Prof Chips. Colleagues, this is a very, very exciting area, very innovative area that we are working with in the faculty. Prof Chips we've launched the niche. There's some very, very exciting initiatives. We learned so much from our workshop that we had, and Prof Chips is going to speak about some of that today. So over to you, Prof Chips.
Thank you, Prof Andipatin. I was just listening to Prof Wegner, and I was thinking, one of the things, can I just ask, can you see my screen?
Yes, we can.
one of the issues that I was thinking of when you were listening is this issue of transdisciplinarity. And I think, this is another area, I think, for the faculty and for all of us to think about how this actually can roll out. So just let me get this going. So today's talk is very much around, and I think this week has been around the SDGs, and I just thought I might remind ourselves on SDG 3, which is to ensure the healthy lives and promoting the well-being for all ages and sustainable development. The WHO has strongly argued that digital health is essential for universal health coverage and is a prime focus for the global SDGs. And so digital technologies is seen as one of the essential enablers of the Sustainable Development Goals. And in South Africa, it also underpins the Better Health for All South Africans enabled by Person-Centered Digital Health, which is the National Digital Health Strategy. So as Prof Andipatin has indicated, so our faculty has created this chair in digital health, and the aim is to create a niche for digital health in the university, and to put us on the forefront of the research on contextual, equitable digital health. This is such a rapidly developing area, and I think it's very timely for our faculty to be having a focus on this. So the focus of the chair so far has just been to start looking at putting up strong collaboration within the faculty, within the university, in the country, as well as internationally. We've established a reference group, as Prof Andipatin has indicated, and we have set together our sort of initial goals and targets of what we would want to actually do. And we started off by just having a survey of some of the digital activities in the faculty. And one of the things we found, in fact, that it's very, very different, lots of different activities. And similar to what you were saying, Prof Wegner, there's really a need for us to really think about as a faculty how we can focus some of our initiatives and have a stronger research faculty focus. Obviously, the chair also has capacity development with bursaries and webinar development. And then there's, I think one of the things that has strongly emerged has been the need for a platform for digital health research in UWC. Again, when I was just listening to you, Prof Wegner, I was just thinking, that there's such a need for us to share our research and what we are doing across the university, because people are working in silos, and we're not always aware of what everybody is actually doing. So I thought I'd start again by talking about what is digital health. And in one of the webinars, Prof Mars from UKZN, who was with us this month, was saying that, there used to be telemedicine, and then it became telehealth, and then it became e-health. And now it's called digital health. So digital health has become this really all-encompassing term. And this has really come about, because there really has been an exponential increase in the use of digital technologies, in general life and in health. And we have seen projects in smartphones, artificial intelligence, robotics. And we're going to have a presentation on virtual reality and augmented reality that we're doing in the school. The whole field of digital health also got impacted by COVID. We all rapidly moved online, and it fits very, very neatly and closely with this aim for equitable, accessible healthcare. So when you think about digital health, we have to include telemedicine, telehealth, e-health, m-health, information communication technology, artificial intelligence, robotics, electronic medical records, data analytics, virtual reality, and it continues. It's very, very broad. But generally, we can think of digital health as using digital platforms to host health services or health interventions that serve clinicians, clients, and the health system. It has to be based on need, and I think that's a very important aspect when we're looking at digital health, and it must aim to improve health and contribute to equitable access. So what I thought I would just do, in terms of, because there's so many activities that are currently happening, I'll just share some of the digital health activities that have been hosted by our school. And the first one I wanted to talk about was M-Health, because M-Health became really very big and popular as well. And we've had a number of M-Health projects in our school and in the faculty that has been conducted and completed. So this is an example of the development of a low-intensity cognitive behavioral loneliness intervention for older people delivered via WhatsApp. This was developed by Dr. Jarvis, PhD student, and Prof. Padmani Manuni from from UWC as well. The interesting thing about this project was that there's a general sort of belief that older people don't use phones as often as other people. They have a lot of hand-me-down phones, that they're not as digitally literate as the rest of the population. So what we did was we did a 3-phased intervention, and we developed, with consultation, we developed this intervention that was actually delivered via WhatsApp, but it has 3 phases. So the first one was around technology acceptance. So one of the things we did was we really focused on building up competency and self-efficacy in using WhatsApp. So a lot of training was done in how to use WhatsApp, how to take photographs, setting up WhatsApp groups. In fact, it was so, this component was so successful that one of the gentlemen in the project is now the technical support officer in the area where they are living. The second aspect was around psychoeducation, because there's a lot of evidence base for the use of psychoeducation for loneliness. So there were face-to-face psychoeducation sessions with the group, but it was supported with WhatsApp messages where we had a dual focus. It was actually encouraging people to use WhatsApp, but also to send them summaries of the psychoeducation sessions. And then lastly, the low-intensity CBT intervention was developed, which had individualized positive worded message that was sent that was addressing maladaptive thinking in older people. So individual older persons were receiving personalized messages to them based on their own kind of maladaptive thinking. And this is just one of the photographs of the training that was happening. There was a manual for them, etc. And when we evaluated the project, because I think that's another thing that's very important, because there's so many projects on the go that it's important to evaluate it. We used a randomized control design with pre and post tests and 1 month post intervention evaluations. We obviously got an increase in WhatsApp use, which was significant. We also found across the 3 time periods of measurement, decreased in cognition of rejection and disconnection, and decreased loneliness levels. At 1 month follow-up, though there was a significant reduction in WhatsApp use, there was still the significant reduction in loneliness was maintained. So this was a very exciting project that we conducted, because we showed that you could use instant messaging and it could be effective in actually delivering a psychological intervention. The interesting thing that came out of this project was that COVID came after the project, and Dr. Jarvis then worked with the South African Depression and Anxiety Group about using WhatsApp to support older people during COVID. So there was a very positive outcome from this project. So that's just, and so there's been a number of other digital projects as well, which I won't, ML project, which I won't go on. The second area that's really of main interest of us at the moment, and is very interesting, is the area of artificial intelligence. So this is a very new area for us in general. And so we did a little project up, the one at the bottom. So just for fun, we actually analyzed Twitter data during COVID. And so for this project, we are working with Professor Tokach from the University of Missouri in our partnership program. And he is a mathematician that is employed in the School of Nursing there. And so what we did was we wanted to look at how nursing was located within the Twitter feeds during the pandemic. And the picture at the bottom, the very, very thick line that you see there is the link between trust and nursing. And so one of the things that came out very, very strongly was that there was a very strong positive association between trust and nursing during the pandemic. So that was a very encouraging find to see. And that was just for us to begin to look at these issues. But the big project that we are currently working on, which is really very interesting, is that we are using machine learning to determine avoidable admissions in an emergency department in KwaZulu-Natal. We are using text mining and random forest algorithms, which is a supervised machine learning algorithm. And what we are looking is we're developing a classification and prediction model to try and identify whether we could associate some of the readmissions with some of the factors. And so one of the interesting things that we saw, which is just amusing on the side, that one of the factors that are emerging is actually a specific doctor attached to the emergency department. But obviously, what is in our beginning data, what we are beginning to see that obviously that there are conditions that are associated with it, and certain behaviors that people come in when that is strongly associated with readmission. And the idea is that this, this can be done obviously through normal statistics, but obviously with loads amount of data and machine learning, we are able to more rapidly and quickly predict this information. So this is a very brand new area. And another area that we are also within the same data set, we are looking at nurse sensitive indicators, and whether you can actually monitor and see whether there are changes around that, and whether you can predict changes in your nurse sensitive indicators. And we are interested in looking at nursing records as well. Another activity that we're also having is just looking, and I think this is probably broader, it's much broader than nursing, but we're focusing through a PhD student and through a collaboration with the University of Turku in Finland, we are looking at the issues of the digitalization of nursing. And I think this is an issue for all of us with all the changes that are occurring. We have to consider the digitalization of our workforce and our training of our students for this. So we are currently looking at a review of technology being used in nursing, ranging from telehealth, electronic records, point of care technology. So there's a lot of current interest in the digitization of touch points of care. There are also things like electronic lift systems, smart beds, digital monitors, automatic IV pumps, wearable technology, smartphones. And one of the Turku University students is developing they've got a very innovative design, a department, and they also have nurse engineers. So they have training for nursing and engineering students that come together to develop innovative devices. And so one of the things that are developing at the moment is to measure pain in unconscious patients in ICU. The second project that we are doing with them as well is we have a project with them where we are looking at the use of smart gloves for CPR training. And we will be, together with them, also will be developing a training course around these issues. And as I was mentioning, the issue of machine learning to improve nursing records and nurse sensitive indicators. So that's just like a little bit of a taste of what the kind of things that we're doing and have been doing. But there are some principles, and it links to what Prof Wegner was saying as well. It should be based on need. Any digital health activity that we have, it should be user-centered. I mean, user-centered is one of the key issues that you will see in reading about design of technology. It should be co-designed, and it should involve technology, psychology, bioinformatics, ICT, and research, very, very much a transdisciplinary focus. It should also be located in, I think, an ethical social justice framework, because we assume that technology will improve access, but as we know during COVID, that not everybody has access to technology. So that in itself can be a big barrier. So we should have technical innovations that are contextually and community focused in creating social value for the people that we are working with. And then obviously the issue of knowledge translation, implementation science. I mean, I think we should, they will talk about the 1,000 pilots that have bloomed in digital health, but we have to start looking at issues of scalability and sustainability, affordability, infrastructure, human resources, and digital literacy. So the way forward for us is the development of partners, which we are very busy actively doing at the moment, and then to establish a major collaborative transdisciplinary digital health case study based on these key principles and combining it with rigorously evaluated interventions. So we're anticipating that there will be a needs assessment. And so similar to the issues that you were thinking about, Prof Wegner, e-readiness assessment. So no digital health project can be done without actually even looking at, what is the level of internet access and availability in the area that you're working. So looking at infrastructure and then identifying a few best practice case studies to show what can actually be done.
Tips, you have a couple of seconds.
Yes, this is my last two slides. So there are a lot of areas that are of interest going forward. The whole area of patient or person-centered health, predictive analytics, the machine learning that I talked about, and a big challenge for everybody is interoperability, because when you've got thousands of different digital projects, we have to be able to, the data can be captured and used. And then the issues of governance, workforce, and ethics, looking at ethical issues in the digital transformation of the workforce. So I think digital health has a strong potential for universal health access. and has tremendous potential for us to enable access to healthcare and SDGs. But it should be located on in an ethical framework. It should be needs-based, and it should ensure at the end of the day that we are creating equitable access to care and not presenting another digital barrier. Thank you very much.
Thank you very much, Prof. Chips. I think that was really an eye-opener in terms of just how far the field has basically progressed. Sorry, my camera's just taken a while to switch on. Colleagues, are there any questions, any comments? Yeah, I think your presentation will probably also linking very nicely with the following presentation, which is around the learning and teaching. But I think what I took from your presentation is the whole issue of not just digitization, but how do we begin to train our students to prepare them for the digital world. And yes, we have had to migrate very rapidly to the digital space. But I think when we're talking about training for digitization, we're looking at a completely different field. Colleagues, I don't see any comments in the Q&A. So we can move on to Prof. Titus, who is our next presenter. Prof. Simone Titus is an associate professor, and she's the teaching and learning specialist in the interprofessional education unit in the Faculty of Community and Health Sciences at UWC. She graduated with a PhD in education from the University of Cape Town, where she developed an interest in the use of emerging technologies as a tool to mediate learning. Her special interests are focused on game-based learning and using emerging technologies to foster cross-cultural interaction, learning, and engagement in higher education. She is a recipient of the Black Academic Advancement Program, where her specific research focus is on the use of augmented and virtual reality in the health sciences education. She's the current chairperson of the Western Cape Region branch of the Southern African Association of Health Educationists, SAHE. Welcome, Dr. Titus, and over to you.
Thank you for that warm introduction, Prof Andipatin. I just need to share my screen. Melanie, you can please stop your share. Thank you. Colleagues, good morning. Today, I am going to be speaking about how we can possibly drive knowledge through the use of augmented and virtual reality, and how, if we look at Agenda 2030, how we can develop sustainable spaces for interprofessional education as well as health. So Gilbert in 2013 indicated that the world is cognizant of the movement towards transforming systems for health through interprofessional education and collaborative practice, with the purpose of improving care, population health, and provide this work experiences, as well as to reduce the cost of service delivery and to realize universal health coverage. And this awareness provides a unique opportunity for global IPECP community to build upon and develop scientific confirmation of the great truth of IPECP. I'm not here to be an evangelist for IPE and IPECP, but I want to link this to how we consider what is currently written in the Global Education 2030 Agenda, which speaks about how we drive knowledge through transformation in higher education and how we do this for the purposes of sustainability. And so this particular report speaks about and makes emphasis that higher education institutions must take a stronger role to tackle the world's most pressing issues. And they do this by summarizing it through three interrelated themes. The one theme, and it links to what both Prof Wegner as well as Prof Chips indicated around the move towards inter and transdisciplinary modes of producing and circulating knowledge. And we need to think about how we're going to do that. The next theme looks at how we can become open institutions by fostering this kind of epistemic dialogue that relates to knowledge and diverse forms and ways of knowledge. And lastly, the demand for a stronger presence in society, which I think we do at UWC, through proactive engagement and partnering with societal actors. And so just again, for me as a reminder, and for those who are here today, my particular talk today focuses on quality SDG 4, which is quality education, where the aim is to ensure that this inclusive and equitable quality education to promote lifelong learning opportunities for all. very often what we don't realize with some of these SDG goals is that there are certain targets that need to be reached, and this particular goal has 10 specific targets, and my focus on my talk today looks at 3 of those targets, which is 4.3, which looks at affordable and quality technical, vocational and tertiary education, which includes university. It looks at 4.7, which speaks about ensuring that all learners acquire knowledge and skills to promote sustainable development. And then 4B, which is about substantially increasing scholarships available for developing countries. So the question, that I grappled with was, well, if we have these targets, how can augmented and virtual reality be used to meet those targets? That's the one question. And then what role can interprofessional education play within that space? And if we look at what that means, for people who might not be familiar with the field of interprofessional education and IPECP, is that interprofessional education is a concept that is used for health professionals, where it's an initiative that involves students from different health professions, where they learn from, with, and about each other. And the ultimate goal then really is to improve quality of patient care. Interprofessional education and collaborative practice is widely recognized as a potential route to improving the quality of patients' healthcare experience. That's 1. Improving the health of communities. That's 2. Communities and populations. Reducing the cost of healthcare delivery. That's 3. And improving the work experience of service providers. And this is specifically known as the quadruple aim. These definitions, in and of itself, actually also speaks to how we might consider SDG 3, which Prof Chips also spoke about, that is related to good health and well-being. But that is not really the focus of where I want to take this conversation today, because looking forward, although IPECP is poised to facilitate the increasing demand of an effective teamwork from health providers and partners at the age of, we're living in a society that is extremely complex, and at the same time we have this technological advancement, especially in health diagnosis. If we look at, for example, what Prof Chips was speaking about in terms of AI, as well as the management within healthcare settings. And just randomly, yesterday, the IPR Global actually released a discussion paper that stated that IPECP would be an integral component in actually promoting patient safety and, holistic care, but it is hampered by silos. And so how can we then use augmented and virtual reality within the space? So to understand what that is, augmented reality, for example, uses a headset or a smartphone to overlay image or content into your physical world. So it adds a digital artifact into your own world by using your camera or the screen of your tablet, where digital models are superimposed into your real world. And so you as a user are then able to interact with this digital artifact within your surrounding environment. Whereas virtual reality is immersive, where you as a user don't put on a headset and interacts with a completely computer-generated environment. And so you can also you can sense sight, hearing, motion, because you are fully immersed in the synthetic environment, because it mimics the properties also of a real world. So the question then is, why do we then want to use virtual reality and augmented reality, and what are the benefits there are for interprofessional education and health education in general? So virtual reality and augmented reality are seen as current trends in medical education, because it's seen to be a good construction of the artificial or the artificial world. And the key element thereof is it allows for increased student engagement because of the high level of interaction. It also allows, or it is said to facilitate skills and that students require to, for engagement and interactivity and enjoyment. And so because students need to gain various skills and knowledge throughout their time at university to become practitioners, subjects like anatomy and physiology, which are actually the cornerstones of health professions education, it is therefore deemed to be one of the more appropriate measures to reach some of the outcomes when learning anatomy and physiology. Because if students are unable to perform investigations effectively, for example, if they don't know structure, function, and location, the kinanthropometry around anatomy, they might not be able to, meet the learning outcomes. And AR and VR is seen as a potential way in which they are able to interact and engage with these types of learning materials, and execute investigations correctly where this is concerned. So, within the virtual reality and augmented reality space, the integration of these digital technologies and the physical world to create virtual simulations in a physical space has lots of merit. So what are the benefits for IPE and health in a post-pandemic environment? The EduCause report indicates that for health sciences students, they can develop scientific literacy, problem-solving skills, and content knowledge by interacting with simulated environments. And the technologies is therefore well-suited for experiential learning, which includes that idea of, reflection and reflecting on your learning experiences. And so through 360 images, you'd often find that these simulations, whether it's in a video or an AR or VR component, it enables users to actually visit places that they might not otherwise be able to access, such as inside the human body. So it provides this rich contextual learning because now students are able to access a world that is impossible to access. They're able to manipulate the world, and they're able to, for example, navigate inside veins and arteries without the risk to a real patient. And over and above that, it allows for the development of core competencies. And if we look at IPE, we consider some of the CANMED's competencies, such as teamwork, effective decision-making, communication, and creative adaptation of global resources to address some of the local priorities within our higher education environment. So again, providing opportunities that is authentic and it appeals to the multiple learning styles of various students. So the picture on the left is an example of a case study which is developed by JIG. JIG is now the new service provider for UWC, where they are able to create content in three-dimensional spaces for UWC. And I'll provide you with a lot more information about this as time goes by, preferably still this year. So what you see on the left is a panda baby warmer. And this was developed because remote nurses during COVID could not have access to a panda baby warmer. And while they were studying on their own, they weren't able to adequately prepare for any kind of exam because they didn't have access to this type of equipment. So they lacked the hands-on experience because they were in remote areas and they didn't have access to this device. And so what JIG did for them was they developed and embedded this particular panda baby warmer into the LMS. So I'm just going to take you there quickly. I'm just going to see if I can I'm just going to stop the share and I'm going to start a new screen share just to show you exactly what it looks like. Let me see. Yeah. Okay. I'm on Chrome. Can you see this? Can I just get an indication? You're seeing a panda baby warmer?
We can. Yes, we can.
Good, thank you. So, Prof Chips, I think you might like this. So, the panda baby warmer, this is an interactive, it's not an interactive environment, but it's a learning environment where they show you exactly what the panda baby warmer is about. There are 52 slides. I'm not going to go through all of them. And it's used immediately after a baby's birth. And it allows for the purpose of providing comfort for the baby while the health is assessed by a pediatric team. As you can see, I can rotate this panda baby warmer in all directions. And if I go to the next slide, it will tell the student, listen, you need to connect the panda baby warmer to the wall socket. So it will show the student where the wall socket is. Usually you can click and it'll have a red light or green light. It will then tell you connect the oxygen and the air from the wall to the panda baby warmer. So these are all obviously areas that I think the student may be familiar with if they have been on a clinical platform. It will then say turn on the second switch at the back of the cot, which can be left on permanently. So it gives students a step-by-step walk through in terms of how the panda baby warmer needs to be done, how to adjust, how to make it warm, how to put it in warm-up mode, how it will go to 50%, how to connect and actually turn on the air and the oxygen. And at some point towards the end, the student will have to also put the baby in the panda warmer. So all the comments, instructions for the student is at the bottom. So check the suction, switch on the suction toggle, you know, sort out the tubing, use the suction dial, by rotating it clockwise, and it will indicate to the student, and obviously they can move this as they wish. I have posted I'm going to stop the share and move back to my my own presentation. So for those who are interested, there is a QR code to take you to that particular jig. And if you do want more information about jig, we will probably post some more information to staff closer to the time. So that is just one example of how an asset can be developed for one particular case. But if you think about doing something, the same activity, but involving different professions where a baby, for example, might have different conditions that a physiotherapist can engage with, an OT, a social worker, etc. I think that it might have good outcomes for how we deal with developing assets within our faculty. So the research I've done in the CHS faculty, I'm just going to report a little bit on a cross-sectional survey that I conducted in 2020, 2021, and 2022, where I looked at the baseline understanding of virtual reality and augmented reality of our first year students in the faculty, specifically nurses, dentists, sports science, OT, dietetics, physiotherapy, and social work, using Google Forms, and I analyzed it using plain old inferential and descriptive statistics. I did an intervention with 3 departments, SDS, Physio, and OT, where we developed lessons of the skull, just as a test to see how students interact with this learning environment. And this was, I've done on the EON platform, but all of this will soon be available on JIG. And we built a lesson.
About a minute left there.
Okay, yes, that's fine. And we built a lesson just using, just using the skull, and students actually really enjoyed it. And we also built a 3D walk of our campus. So in terms of familiarity with AR and VR, our students are actually saying, you know what, we are not familiar with virtual reality or augmented reality, because the majority of students are saying that they don't know. But they're also saying that, you know what, we actually only anticipate that this will reach our health sciences classroom in 2 to 5 years and 5 years plus. In terms of interprofessional education, when I looked at communication as a core competency, it indicated that students felt, well, the perception that, or 70% of them said that, yes, this could be used as a mode for developing communication. And I'm just going to read one quote where students are saying, you know what, we can use augmented and virtual reality space to create scenarios that need to be solved using knowledge that come from interprofessional teamwork. And that's a first year student. Students are actually saying that they don't use it because it's too expensive. And if we look at what the SDGs or the Agenda 2030 is saying about making it affordable, we then need to come up with ways in which we can do that. And so these are just a few quotes from students in terms of saying, you know, how we can use these platforms to improve core competencies like communication. And the student is saying, you know, it can strengthen interprofessional relationships and therefore increase work ethic. But there were also obviously negative comments that looked at miscommunication. And so I just want to end off by just stating very quickly my concluding thoughts. I think I'll take about 30 seconds to do this. The exact impact of augmented and virtual reality in higher education and health science education is still largely unknown, because this type of technology is actually not new to our students, because it's refuted because majority of our students in our context are actually not familiar with augmented and virtual reality. And so if we look at the fact that they're going to enter the workforce where they might have to use this, and we look at what the Agenda 2030 is saying, you know, this is a unique opportunity for institutions to look at inter- and transdisciplinary modes to produce and share knowledge. It's you know, affordable and quality education is viable through the use of augmented and virtual reality, as it may provide an opportunity for practicing IPECP. Knowledge and skills development could be attained within virtual worlds using authentic learning. And then higher education institutions should respond to some of the initiatives to develop partnerships through internationalization and proactive engagement to negotiate scholarships that may build capacity in the field of health, science, technology, interprofessional education, and health. With that, I thank you. I'm really sorry if I went
Sure.
over my time. Thank you.
No, it's fine. Sure, it was a marathon. I could hear you rushing, but thank you so much. There's a question in the chat from Prof Wegner. She was asking about the budget. Do we have a budget set aside for acquiring AR and VR technology at UWC?
I don't deal with budgets, but Laureen Pratsky just also put into the chat because she deals with some of the things around JIG. So the news item is that it will be going out to UWC staff and students that JIG space will very soon be available. And there is a new digital hub, which I think is being built on Voortrekker Road. So I don't want to say that there's a budget, but I think that there are resources that the institution has now made available that allows us to create artifacts and assets for augmented and virtual reality, and JIG space will be the landing space for that. And then we also obviously have the PG DIP in immersive technologies, which is housed in the science faculty, and that will also obviously start again next year.
Thank you, Prof. Titus. I don't think there are any other questions, but colleagues, if you'd like to contact Prof. Titus, email address should be on the UWC mailing list. So please feel free to contact her. This is definitely the space. We are all moving into the virtual and augmented space. And it's always surprising for me when I see many young people are still not familiar with AR and VR when it's used so often in gaming. But obviously that speaks to access and issues of resources. And many of our students come from backgrounds where they cannot afford these VR glasses. But yeah, it presents so many opportunities for learning, because that's the one area that you alluded to, the multiple ways in which students learn. I think the question I have, Simona, I always think, are we becoming cyborgs? What's happening to us as human beings? But that's a conversation for another day. So thank you very, very much. It was very, very interesting. And I'm sure all of us learned a lot. Colleagues, our next speaker is Dr. T Mthembu, also from the Department of Occupational Therapy. And he holds a BSc in OT, Master's degree in Public Health, and his doctorate from UWC. His teaching areas include trauma and disease, chronic diseases, older adults, and healthcare ethics in occupational therapy. He is a member of the Sub-Saharan Africa Regional Institute SAFRI Fellowship, and he received the National Research Foundation's Black Advancement Program and the Tuka Grant now recently. Welcome, Dr. Mthembu. You have 15 minutes in which to present, and we will leave some space for Q&A or comments if colleagues would like to make some comments. So over to you. Dr. Mthembu, are you there? We can't hear you. Can anybody hear Dr. Mthembu? Melody?
I'll just check with you.
Okay.
Can you hear me now?
Yes, we can hear you.
Thank you.
You can go ahead.
Okay, thank you. Good morning, colleagues. What I'm going to present today is the exploration of students' perceptions about the importance of family support within their academic performance. So family support is one of the things that we need to look in within the university and also within the teaching and learning, because it's one of the significant things that it adds value to student success and also their retention within a university. And when we check that, we also notice that there are pressures that emanate from finance, emotional and psychological, as well as social and material, that affects students from performing within their academic. But research has already shown that people who, especially the students that are at higher education, if they get more support from their families, they are able to perform well. But we have noted that nothing has been done much when it comes to family support within academic performance of students in higher education. So this led us to ask ourselves, because universities are also trying in academics to provide support, but little is known about what families are doing to support the learners that are joining university in order for them to progress. So this led me to, and the other colleagues that I was presenting with, to think about the research that we need to do. And this research that I'm presenting to colleagues is a research that has already been published. So the paper already published in 2022. So that is something that I wish to share with you. I hope you all understand. And then I just want to highlight that the study aimed to explore the perceptions of occupational therapy students regarding family support in their academic performance. And this was an interpretive, qualitative, exploratory, descriptive study that was conducted with OT students, and 6 students participated in different focus groups, and the focus groups were also analyzed using thematic, and trustworthiness was also respected as part of ensuring that the data was providing a quality information. Then I would also share. Yes.
Sorry, Doctor. Can you kindly put your presentation into slideshow mode, please?
Okay, let me do that.
Thank you, Doctor.
Can you see it now?
Yes, perfect. Thank you.
Thank you so much. So I've already covered this slide. So these are the number of participants that participated in the research study. So the first thing that emerged from the study is that the students, they've highlighted that their parents were providing support through the times when they're experiencing academic pressures. One of the students highlighted that I call them any time of any day and be like I'm struggling, and they will support me emotional and make me feel like they want to be here again. So this is a first year student who was highlighting that. And then a fourth year said that I've looked to them for mental support, especially during these hard times, like studying for examination, orals, OSPE. Sometimes you need someone to practice with, and even though they don't understand, it's nice to just have someone there just to listen and hear out. So in moving to theme 2, theme 2 is where the student were highlighting that some of their parents doesn't know much about occupational therapy. However, they are also assisting them to present and also do some of the work, even if they're experiencing pressure that are related to academic. And one of the participants highlighted that I think my parents didn't really know what OT was, as they thought it was just easy. It started getting harder, then they started to realize that I need little more support. These already highlight that the students, they also need support from their families because it's part of their studies and they also need them. So moving to theme 3, I physically took my assignment and she looked at it. So this is where the students were highlighting that within the occupational therapy department, there is support that is being provided to students so that they can be able to progress in their studies. One of the participants highlighted that, I quote, I feel our department is actually very close and supportive. Like if you are struggling compared to other departments, you are going to struggle, you are going to fail. However, if you're struggling in OT, they are going to help you. They are at least going to try to help you, but they can only help you if you're letting them know that you are struggling. If you don't say anything, they won't know. Another student highlighted that I had an amazing emotional support on my side from one of the educators at the department. Looking the findings of the study, it's highlighting that academic support is needed to promote sustainable developmental goal number 3, which is why it's highlighting the importance of health and well-being, looking that the student, they are also experiencing academic pressures, and also that on its own, it end up affecting goal 4, which is the quality education. Hence, it's important for the participants to also get support from their families and also support from the department. And one of the theory that also supports this is the parental autonomy support, which was evident from the study that the students, they've realized that they need to take initiative so that they can also access support from the department and also from the parents. And this on its own, it needs to include communication as one of the competencies that we think about as part of being a health professional, that builds on compassionate presence and deep listening in assisting the autistic students so that they can develop an interdependent relationship with their families and educators. And also the findings already highlighted that the student, they need to have inner capacities and strength that will assist them so that they can be able to be resilient when it comes to academic pressures. So one of the recommendations that also needs to be highlighted is that within the university and also the families, we need to ensure that we support the health and well-being of our students so that they can be able to work harder and perform within their studies. And also the student, they need to also strengthen their relationship with their parents so that the autonomy and support will also be given to them through enabling opportunities, and the student educators can also form a good connection that will also strengthen sustainable developmental goal of quality education by making sure that the student, they also get knowledge and skills and competencies that will make them strong, so that even if they're facing difficulties, they will be finding ways of how to deal with those difficulties. In conclusion, quality education necessitates collaboration between parents, students, and educators to address the academic pressures that influence academic performance of the student in higher learning. This is already highlighting that even if a student is an adult in a higher education, but family emotional support is one of the integral part of academic performance among autistic students, as it's already been highlighted. A sustainable and invigorating and effective student support program should incorporate mental health, academic, emotional, physical, and psychological, considering also financial and spiritual within and virtual as a key determinant of academic performance. I thank you.
Yeah, thank you, Dr. Mthembu. Colleagues, another important issue that we all faced with in academia is the well-being and the mental health of our students. I think within the last 3 years, we're seeing a huge increase in mental health issues among young people, particularly suicidal ideation and suicide. So I think this is a very, very important area that we all need to take note of. What I found interesting, Dr. Mthembu, was the comment around parental and family support to learners. And many of us, we kind of think that our students and our children are basically young adults, and therefore, you know, they can be left on their own. I think what the last couple of years showing us is that our support is even more important at this stage of development. So yes, this was a very, very interesting presentation. Colleagues, if there are any questions, any comments, please let us know. Dr. Mthembu, if you can stop sharing your screen right now, that would thank you very much. If there aren't any comments or questions, we can move on to our following speaker, who is Dr. B Schmidt, and she is from the School of Public Health. She's a senior lecturer there, and she's affiliated with the Cochrane, South Africa, at the South African Medical and Research Council. Dr. Schmidt is a public health researcher with training in both anthropology and epidemiology. Her expertise is in conducting systematic reviews of public health and health systems interventions. She's also interested in the implementation and evaluation of knowledge translation interventions that can enhance evidence-informed decision-making. Thank you, Dr. Schmidt, and it's over to you.
Good morning, colleagues. Thank you, Professor Andipatin. Just bringing up my slides. I hope that you can see them in full slide mode.
Yes, yes, we can.
Okay. Yeah, so this morning I'll be speaking on how we can apply knowledge translation to advance the ways in which our research can make a difference in policy and practice decision making. This presentation speaks to goals 3 and 17 as knowledge translation promotes collaboration between researchers and decision makers for strengthening health decision making that can ultimately lead to good health and well-being. Yeah, I think we've seen from all the presentations this morning, the word knowledge translation has come up a few times. So I just want to acknowledge that there are different ways in which we may refer to the same thing. I primarily just call it knowledge translation, and I'll also define that in this presentation. So yeah, this is just a reminder for us to note that decision-making processes are often very complex and unpredictable, where decision makers have to consider a wide range of things, including the best available research evidence, but also considering resources and people's specific needs, experiences, as well as the environment and any other sort of political contextual issues. So given the complexity of decision-making, our goal as researchers should not only be to produce relevant and good quality research, but it should also be to increase the interest and influence of our research, of course, acknowledging that it is only one type of evidence in the decision-making process. So I'm not saying that, you know, things like political context, culture, or resources don't matter or shouldn't matter in the decision-making process, but rather that knowledge translation, which I will define, can help promote or enhance research specifically in the decision-making process. And of course, considering that research competes with other types of evidence in decision-making. So the Canadian Institutes of Health Research provides this definition, which I think is quite well known, but I like the one on the right-hand side in the block that is a more simplified version of defining knowledge translation, which is from a colleague at the Stellenbosch University. And this definition says that knowledge translation is about getting the right information to the right people in the right format at the right time, at the right place in the right way to influence policy and practice decision making. And so the components that you see that are highlighted in blue are actually what comprise a knowledge translation strategy. So there are different models of knowledge translation. And I think the one that is most beneficial and also reflective of our values at UWC, as also what I've heard from the presentation, from the presentations, is the integrated knowledge translation model, so Model D, because it promotes the engagement of different end users by researchers. So researchers would engage policymakers, clinicians, patients, etc., as active participants in the research process. This also means that researchers and end users are able to collectively identify research problems, create knowledge or review it, package that knowledge into formats that is useful for making decisions, monitor the real use of that knowledge in policy and practice, and evaluate the outcomes of new policies and practice, as well as being able to sustain the ongoing use of research. So now that I've defined knowledge translation, I think the question for us as researchers is how can we apply knowledge translation practically to promote the uptake and use of research? So what you see here is a knowledge translation strategy, which is a summary of who the relevant stakeholders are that we want to promote our research amongst, the purpose for engaging them, what we will tell them, so the message that we have as researchers for our stakeholders, how we'll engage them, for example, the format or the mode of communication. And we'll also have to decide who should engage them. So sometimes as a researcher, I'm not the best person to engage a particular stakeholder, but is, thinking about whether there's another colleague or someone else who has a close relationship with a stakeholder. And also, lastly, considering what is the best time to engage and what resources are needed to do so. And I think for us as researchers, it's really acknowledging that it takes a lot of time and resources to do knowledge translation or community engagement or participate in action research, etc. So how do we go about developing a knowledge translation strategy and implementing it and monitoring it so that we know how to promote the interest and influence of our research amongst decision makers? The first step is to carry out a stakeholder mapping exercise. A stakeholder map is something quite simple to develop. As you can see on this image, you can basically just brainstorm who you think is interested or who can influence your research or put your research findings into actions. So it's both those people that can affect or be affected by our research. And so common stakeholder groups for health, for example, are patients, the general public, carers and families of patients, communities, healthcare professionals, healthcare managers, policymakers, research funders, and even other researchers that we collaborate with. And usually when we map stakeholders, it's good to think of specific individuals or organizations that we can approach. And also the map itself can be done in any form, like on the slide where it's a mind map or a sticky note or in an Excel spreadsheet, for example. Okay, so step 2 is doing a stakeholder analysis. So once we know who all our stakeholders are, it is important to then understand where they are in relation to our research. So what position they sort of hold in relation to our research. And so the table that you see at the bottom of this slide is one way of analyzing our stakeholders, which is looking at their interest in relation to our project, their influence, their importance in relation to our project, how they can contribute or how they can contribute to or block our research. And in the second last column, we can classify the stakeholders based on where we think they fall in terms of their interest and influence. And so the blue box that you see at the top is what we call a stakeholder matrix, which can really help us with that, where we can classify stakeholders into 4 types: blockers, champions, avoiders, or silent boosters. So the y-axis maps influence from less to more, and the x-axis maps interest. The y-axis maps influence and the x-axis maps interest from less to more. So for example, if you feel like a particular stakeholder has a high level of influence on the research and is associated with any policy or practice decisions, but doesn't seem interested in the research project, the strategy in managing that specific stakeholder would be the top left block, which is to keep them satisfied. And your strategy to manage them, of course, can change over time. And so in the short term, you may keep the stakeholder satisfied, but in the long term, you may identify a window of opportunity where you could convince them that your research is important, or where you could use a champion who is in the top left, in the top right block to advocate for you on behalf of your research project. So step 3 is about implementing and monitoring our KT strategy. So once we have a strategy, the idea is to start implementing some of the engagement activities amongst the different decision makers or stakeholders. And once we've done that, or as we're doing that, we want to monitor our engagement. This is what this slide is about. So The purpose of monitoring is to actually be able to see whether we need to adjust any of our KT activities or processes. What we see is we want to be able to monitor specific indicators. So we need to decide on how we'll collect the data for those indicators and how frequently we want to do so. So monitoring can be quite simple. It can be as simple as counting the number of interactions with individual stakeholders. And this can be done through this tracking sheet. So where we capture any interactions like phone calls or emails or meetings with that stakeholder. And this can really help us monitor our interactions. So in terms of whether we need to increase how much we engage with that specific stakeholder or decrease the interaction. It can also help us plan when is the best time to engage with a particular stakeholder. So we may choose that there are certain stakeholders we want to engage with from the beginning of the research, but there may also be other stakeholders that we think are more appropriate to actually engage with once we have started the research and can engage them around a particular activity that captures their interest. So the monitoring is really about being able to see patterns from the way that we track our engagements and take specific actions to advance our engagements or how we can support decision making. So I've just given a few examples of KT indicators, and I think the field of evaluating knowledge translation or community engagement, etc., is quite vague still, but these are just examples of indicators that could be used. And indicators are really determined by what we want to achieve. So what we want to achieve is ultimately what we want to monitor whether we've achieved that. For example, we may choose to engage a particular stakeholder to establish a new relationship because we're wanting to do research on a particular aspect. And so the types of things that we may want to monitor in terms of our KT with that stakeholder is, for example, the number of research outputs that we develop together, and we may want to decide on things that we want to disseminate jointly because our stakeholders may have a particular interest, or they also may have the influence on others. So doing research with them and therefore monitoring our outputs in terms of our joint work can be a helpful indicator. Could also be helpful to see if there are any opportunities for future collaboration, whether it's for research, policy, or practice. But also we could just monitor whether there's any ongoing sort of information sharing between us and that particular stakeholder, and that could give us a good indicator in terms of the relationship that we're building with them. So this table is a simplified version of a knowledge translation evaluation plan, which is about, this is really about planning the evaluation. So this is once we've implemented specific activities and processes for engagement, and so wanting to then evaluate whether those activities and processes are working or not. And the things that we think about in an evaluation plan like this is what we want to achieve by engaging the particular stakeholder. So what are the outcomes of our engagement? How we will achieve these outcomes? So how will we actually achieve the specific activities and processes that we've implemented? What would success look like? So what do we think would be the best outcome in terms of the engagement that we have with the stakeholders? How will we measure progress? And I think measuring progress for knowledge translation can draw on a variety of methods. So it can draw really on qualitative and quantitative research methods. Evaluating a knowledge translation strategy in itself can be a research project. But it can also just be a practical evaluation of progress where you get ad hoc feedback from stakeholders, or where you ask for them to give you their perspectives on a particular dissemination format. So for example, we may assume that stakeholders want things like policy briefs, but you know, we could ask them simple questions about how can we package that policy brief in such a way that it provides information that is useful for them.
We have about a minute left.
Yes, I'll be concluding. And then in terms of the evaluation plan, the last thing is also to consider when will progress be measured and who will be responsible for measuring that kind of progress. So in this short presentation, I've practically shared how we can apply KT so that our research makes a difference in decision making. The KT strategy, as I shared, is a plan of what change we want to make through our research. And then the implementation is about how we are going to achieve that desired change. And KT evaluation is about whether we have achieved the desired change and to what extent. Thank you.
Thank you very much for that. I think your presentation speaks directly to Goal 17. We're always talking about partnerships, we're talking about stakeholders, but very often it kind of happens by trial and error. You know, we don't go through formal processes of looking at what it is that we're really needing and how what we're needing, who it comes from, and the impact that kind of engagement will have. So I think this sheds a lot of light on just formalizing everything and gives us some kind of guidelines to follow when we engage, because I mean our faculty is all about community engagement, so this becomes really key to what we're doing. And I think Prof Wegner, it ties up very nicely to the issue of the science hubs as well, because this is all about providing and producing the evidence that we need to show what is working, why it's working, and what is not working. I don't see any comments in the Q&A or in the chat. So Dr. Schmidt, thank you so much for that. And I know that all of us would like to have a copy of your presentation, and I'm sure Melody, you and your team will be sharing it with us. We can now move on to our next presenter, is Dr. M Malema. He's an emerging researcher in leisure, recreation, and sport management. He's a lecturer in the SRES department at UWC, and he recently completed his PhD in sports, recreation, and exercise sciences with the title Guidelines for Leadership Development, using leisure education as a tool for youth with physical disabilities in South Africa. Dr. Malema's research focuses on community leisure and recreation and sports programs with NGOs from disadvantaged backgrounds and health institutions from special populations. Dr. Malema, over to you. If you can just put your presentation on slideshow, please.
Thanks, Prof, for the warm introduction. So what I'll be speaking to the audience about today is an extraction from the overall PhD, which specifically focuses on SDG goal number 10. And the title of this presentation is Leadership Development, Using Leisure Education as Means to Reduce Inequalities Amongst Youth with Physical Disabilities in the Western Cape of South Africa. So this study is an extraction from the PhD thesis, in which it was conducted in 4 phases, but then from the 4 phases, we managed to get about 5 articles. So I'm just gonna briefly speak about, just to give an overview of what each article focused on. So on the first article, it was really just a theoretical framework in which we pulled together different models and frameworks to see how they fit into leadership development of youth with physical disabilities. And that was really the core theoretical framework of the study. And in phase number 1, which was a scoping review, it focused on leisure programs that develop leadership amongst youth with and without disabilities. And this article is currently available on the African Journal for Physical Disability and Health Sciences. And the second phase, which was a quantitative method, looked at the perceptions, or rather investigated the perceptions of youth with physical disabilities about leisure education and leadership development. The article is currently under review, and on the third phase, which was a qualitative study, it looked at exploring how leisure education can be used as a tool to develop leadership. And this article is also currently under review. And the fourth phase, which was the core development or outcome of the study, which was a Delphi method, which looked at actually bringing this whole concept into something more tangible, in which youth with physical disabilities can refer to those guidelines to develop and increase their capacities. So in this study, we argue that leadership development for youth with disabilities is important in order to empower them, to build their resilience, and also to further develop their capacities. This becomes necessary as youth in the country, especially those with disabilities, they are observed as being marginalized and do not have equal opportunities with their counterpart peers. Youth without disabilities, they seem to be ahead of their counterparts, youth with disabilities, in terms of the resource allocation, mainly on leisure and recreation. So it therefore makes planning for leisure services in society, to actually account for youth with disabilities so that they are not excluded in activities in their communities. Worldwide and in South Africa, there are policies, and specifically the one in the Gauteng Sports and Recreation, that encourages for a national and global intervention in which this will see people with disabilities being part of mainstream society. With that being said, it means that they will have equal opportunities. They'll be living independently, having education, employment, and social integration. However, this is not always a true reflection of what is written on paper on our policies into what's happening on the ground. It is therefore unrealistic to expect that community members, especially where these people with disabilities are residing, to become inclusive of people with disabilities without knowledge, awareness, and skills with proper training. Larson and colleagues reported that our current society needs young people with unique skills to address social, economic, and ecological problems that confront them on a daily basis. So we noted that in South Africa, there is a lack of programs that promote and develop leadership and service learning for people with disabilities. So when we look at an international perspective, a study conducted in Spain reported that majority of people with disabilities, they do not have access to health, rehabilitation, social support, income programs, education, leisure, and employment. So when we compare that with South Africa, we note that South African populations are not exempted from the challenges that are reported above. So as an intervention, some of the strategies, specifically strategy 7 on the white paper of rights of people with disabilities in South Africa, it stresses that all policies, programs, and campaigns to promote social cohesion must prioritize educating society about the rights of people with disabilities. So as I mentioned earlier on, that this study focused on SDG goal number 10, specifically target number 10.2, in which it reports that by 2030, there will be empowerment and to promote the social, economic, and political inclusions of all people, irrespective of their age, their sex, disability, race, ethnicity, origin, religion, or economic and other statuses. So as we move towards reducing the inequalities, to empower people with disabilities, strategy 8 of the white paper stresses that access to minimum and affordable services aimed at supporting independent living in their communities must also be prioritized. And this will actually give in more empowerment to persons living with disabilities. And as an argument of this study, youth with physical disabilities, they can actually contribute to the growth of the country and alleviate the constrained resources that are reported in the National Development Plan of 2030. It is therefore desirable to develop guidelines that are relevant and informative to South African youth, specifically on youth with disabilities, to nurture their skills through leisure education programs. So in this study, what we report is that leisure education becomes a meaningful tool to help youth with physical disabilities to become independent. This means that they'll be able to move away from relying on service providers, government and other leisure stakeholders to provide leisure activities for them. Rather, through their education and knowledge about leisure, they become independent, they promote their own activities, and they don't really rely on other people, but then they can actually take initiatives from themselves and also influence other peers that are in the same conditions as them. So that is the main focus of the study, to build these youth with physical disabilities, their capacities, so that they become more independent and less reliant on leisure service stakeholders and providers. It is therefore through leisure and leisure education in which we note that leadership can develop and nurture along with other skills that one learns through leisure participation. Now, through their participation, they develop skills such as self-efficacy, self-identity, and that can help them to become leaders of their own future and of their own peers and in the communities. It is essential for a leader in leisure programs services to possess certain skills, which includes the ability to work effectively with others, insight into leisure trends, ability to develop interest and appreciation in others, cooperative attitudes, and strong sense of dedication, creativity, sense of value, and common sense. Now, these skills are very much necessary because if they are becoming independent from stakeholders, then they actually take initiatives and plan programs in which they want to see what benefits they can derive from that. Now, as part of the recommendations of the overall study, we recommend that there is a need for social integration of youth with and without disabilities to participate in inclusion of leisure and leadership programs. There is a need for opportunities for self-development and improvement, and this should be offered to youth with physical disabilities to build their capacity and to participate in mainstream activities. And furthermore, there is a need for governmental and organizations and NGOs to offer youth-led leisure education programs. With that being said, this would actually create them to be more proactive in leading their own activities instead of having a person without disabilities leading the programs that benefits them. So it should be a balanced program. So this is just to acknowledge all the references that I used. And thank you very much. If there's any questions, you are more than welcome to let me know, contact me.
Thank you, Dr. Malema. Thank you for a lovely presentation. And I know that you are very active in the field of leisure and youth with disabilities. Colleagues, are there any questions, any comments that you'd like to make? There's a question from Prof Wegner, Dr. Malema. What is the next step in this research for you?
Thanks, Prof Wegner. I think I don't know how to answer this, but I think Prof knows from our engagement that there would actually be more implementation stages from here on. So it's not really just about, developing these guidelines. We must actually go into the stage of seeing, are these guidelines viable for this youth? Can they be rolled out to other youth as well? So that, it's not just a sitting document, but then it's something that can be implemented either to the broader audience or specifically to youth with disabilities.
Yeah, no, absolutely. I agree with you 100%. So thank you for that, Dr. Malema. We can then move on to our next speaker, who is Mr. Kyle Jackson. And he's an associate lecturer based in the Department of Psychology. He's registered with the HPCSA as both a research psychologist and as a registered counselor. He supervises at both honors and master's level, teaches at both undergrad and postgraduate level. Mr. Jackson is currently completing his PhD under my supervision, and his thesis is entitled "The Exploration and Development of a Model on the Constructions of Masculinity and Fatherhood in the Context of High-Risk Pregnancy." It's an ethnographic grounded theory approach. Over to you, Mr. Jackson.
Thank you, Prof. Thank you. I'm just going to quickly share my screen. Is it in full screen, Prof?
Not yet. It's not yet.
Is it just loading?
It shows something, but I don't know if it's Melody. Is it full? It's not full screen
clear.
yet. Is it
clear,
full
Mr.
screen?
Jackson. Yes, it
okay.
is.
Okay.
Thank you.
Thank you.
Sometimes when I've got my second screen plugged in, it doesn't always work so well. Let me just try that again.
That's perfect, Mr. Jackson.
Perfect. Okay, great. So the study that I'm going to be talking about today is on fatherhood and high-risk pregnancy, and it's a scoping review that we did alongside some of my honors students. In particular, it's Erica Erasmus and Toby Mabanga. There we go. So in terms of this study, it kind of relates more specifically to SDG 3, which is on good health and well-being. And broadly speaking, it seeks to ensure health and well-being for all at every stage of life. The goal addresses all major health priorities, including reproductive, maternal and child health, communicable and non-communicable and environmental diseases, universal health coverage and access for all to safe, effective, quality and affordable medicines and vaccines. It also calls for more research and development, increased health financing, and strengthened capacity of all countries in health risk reduction and management. So specifically, the study related more to the different targets under SDG 3, which is 3.1 to 7 and 8. And that is to reduce global mortality rates to less than 70 per 100,000 live births. And in the SA indicator baseline report, we are currently sitting at about 133 per 100,000 live births. In terms of 3.2, it's to reduce neonatal mortality to less than 12 per 1,000 live births. And in South Africa, we're sitting at 24.1. And further to 3.2 is to also reduce under 5 mortality to less than 25 per 1,000 live births, and in South Africa we're sitting at 30.2. In terms of 3.7, it's universal access to sexual and reproductive healthcare services, which includes family planning, various psychoeducation workshops, etc. And what we've noted in the SA indicator baseline report is that 57.9% of women and 67.7% of men use contraception within relationships. And then towards 3.8, it's universal health coverage in terms of financial risk protection, access to quality essential healthcare services, access to safe, effective, quality and affordable essential medicines and vaccines, and this was not reported on in the indicator baseline report 2017. So the aim of this study was the experience, well, the background aim is the experience of expectant parenthood is commensurate of relative angst and nervousness, albeit one of overall excitement and joy. However, when pregnancy is regarded as high risk, this experience changes quite dramatically for both parents. So while literature on high-risk pregnancies is slowly gaining traction, the focus is predominantly on the mother's experience, and therefore paucity exists in terms of exploring the father's experiences of that high-risk pregnancy. So this study aimed to determine the current extent of literature focusing on fathers' experiences of HRP using a scoping review methodology. So the study followed Oxy and O'Malley's 5-step guide to conducting scoping reviews, which is split between identifying the research question, identifying the relevant studies, selecting the different studies using inclusion and exclusion criteria, charting that data, and then finally collecting, summarizing, and reporting the results. So how did we do what we did? So we searched 9 different databases through the EBSCOhost metadatabase. The search string that we used was father and or dad, or paternal or high-risk pregnancy, complicated pregnancy, medical high-risk pregnancy, birth complications or pregnancy complications. And the aim here was to try and be as broad as possible so that we could include more studies than not, especially as it relates to the scoping review methodology. We didn't limit the searches to any time frame. But based on the hits that we obtained, the results was within the time frame of 1948 to 2022. The inclusion criteria was that the studies needed to have a focus on fathers and high-risk pregnancy, where studies included the experiences of both parents. Only the data that was reported on that related specifically to fathers was extracted. The studies also needed to be peer-reviewed, English, and where we had full text access. The exclusion criteria focused on where fathers were absent or where mothers had provided their perceptions of what the experience was like for fathers, or in cases where studies did not focus specifically on high-risk pregnancies. So what was the review process? We found 2,190 records. We determined 4 additional records through reference mining, and I'll expand a bit more on that in a second. There were about 149 duplicates that were removed. We screened 2,045 titles, and through that screening, we excluded 2,007 articles. That left us with 38 abstracts that we needed to screen, and we determined that 15 of those abstracts should be excluded. And then we proceeded to full text screening, in which 8 articles were excluded, and that left us with a total of 15 studies for inclusion that were subjected to a narrative synthesis. So in terms of the reference mining process, we kind of split it into 2 stages. So firstly, we had 12 articles that were screened. So we looked at the reference list of the 12 that we had initially included, and we found a further 2 studies that might need to be included, and we put those through the various screening processes. And then we did a secondary reference mining process on those 2 articles and determined that a further 2 should be included. And then when we did the reference mining process again on those final 2, we determined that no further articles should be included. And that's how we obtained the 4. So what did we find through the narrative synthesis? We determined 4 different themes that I'm going to run through. So the first one is the father versus the healthcare professional and hospital environment. The second was the impact of the high-risk pregnancy on fathers. Thirdly, redefining the role of the father after experiencing a high-risk pregnancy. And finally, the focus on fathers' recommendations for support. So in terms of our first theme, the father versus the healthcare professional in the hospital environment, fathers often experienced a lack of communication, neglect, and near total exclusion from healthcare staff. This increased their sense of alienation and insecurity, which exacerbated their anxiety, sense of powerlessness, and role ambiguity. So exclusion was felt mainly on two aspects. So this was in terms of institutional exclusion, where there was a lack of privacy for fathers and their partners, an absence of facilities for fathers to also occupy while they were waiting to hear news of the status of both their partner and child. And this also expanded to professional exclusion, where there was generally a sense of felt lack of support, information acknowledgement of the role that fathers can play within a high-risk pregnancy context, and the trauma that they experience, particularly when the high-risk pregnancy becomes life-threatening, more specifically. And this negatively affected the help-seeking behaviors of the fathers within these contexts. Secondly, the impact of the high-risk pregnancy on fathers. They identified that fulfilling a supportive role was central to their function during a high-risk pregnancy, and the supportive role included maintaining employment responsibilities, so ensuring that they were still earning an income, and to ensure the sustainability of the household, even through the increasing medical expenses that they were facing as a result of the high-risk pregnancy. It was also important for fathers to ensure that they managed the household effectively, and this was characterized by a reorganization of the self and the sense of self by assuming both primary caregiver and breadwinner responsibilities respectively. So this also included situations where there was more than one child. So where the children were still at home, the father would have to split his time between ensuring that those children were cared for, as well as trying to be at the hospital to support and care for his wife and, in some cases, unborn child. Most importantly, supporting their partner and child at the expense of his own needs, which often led to near total exhaustion of mental resources. So there was a strong dissonance between outward expressions of emotion and internal felt experiences. So fathers highlighted the importance of remaining strong and secure, which often meant that fathers did not show emotion, even though they were not coping. And this was specifically done to try and avoid mothers from experiencing increased anxiety and stress and concern towards the fathers, so that she could rather focus on her own health and healing. But this dissonance that was experienced by fathers led to an increase in pathology, specifically major depressive disorder, and oftentimes an unrecognized trauma, neglect of his needs, and the maintenance of various conflicting roles led to an increase in anxiety, fear, guilt, and burnout, which culminated into long-lasting effects well after the birth of their child. This was also represented in fathers witnessing their partners in pain and not being able to intervene, leading to a position of powerlessness, conflating their vulnerability and fear for their partner and child. The third theme was the redefining of the role of the father after the high-risk pregnancy. And this theme kind of dovetails the previous one in the reorganization of the self and the sense of self. And what was quite pertinent in terms of the findings of the scoping review was that hegemonic masculinity still remained a central concept in several of the studies, and that was determined by showing strength, often neglect of his own needs, maintaining the supportive and provider role above all else, which in many cases impeded his help-seeking behaviors. This also increased burnout and symptoms of pathology. So as I mentioned previously, major depressive disorder, trauma, anxiety, and both preparedness and complication readiness served as a key factor in minimizing maternal death. And this was often in terms of increased care and knowledge around some of the complications that may arise as a result of the pregnancy and high-risk pregnancy. And preliminary findings from my PhD indicate that this served to decrease fathers' sense of helplessness and role ambiguity. And then in terms of the fourth theme, the focus on fathers and possible recommendations, fathers called for improved communication support within the healthcare system. This also increases their felt sense of control and coping through validation of his presence. Ultimately, this also increases the support received by the mother and indirectly the unborn child if the father feels that his role is validated and he has a sense of what he can offer to try and support his partner and unborn child. And the current context converges the dissonance between social expectations and the experiences of men. So for example, we have policy for male involvement, but fathers often experience near total exclusion within the healthcare system, and that dissonance between the two. And so incorporating a family-centered approach is crucial to taking this agenda forward. So in terms of the conclusion, the findings of the study highlighted the importance of the inclusion of men and fathers in supporting both his partner and unborn child. And this related specifically towards healthcare institutions and healthcare professionals. The findings further illustrated the long-lasting impact of trauma felt by men, which often constrained his ability to provide support for his family. And preliminary findings from a PhD indicate that often the interviews that take place with fathers is the first place in which he finds a space within which he is able to talk about the trauma that he experienced, and this is usually several years after the experience of the high-risk pregnancy. So a family-centered approach is needed to further support the family and the impact of the high-risk pregnancy on all members within that family unit. So how does the study relate specifically to SDG 3? So in terms of 3.1.
Jackson, you just have 1 minute left there.
It's my last slide. It relates specifically to the theme of the impact of a high-risk pregnancy on fathers and redefining his role. The same applies to 3.2 and how we redefine the role of the father. In terms of 3.7, we look at the theme in terms of the father versus the healthcare professional in the hospital environment and providing areas for support during the high-risk pregnancy. And in terms of 3.8, the same applies there as well. So thank you for listening to my presentation.
Thank you, Carl. That was really a good presentation. And as you were talking, I was thinking about two of the studies that my students are conducting on PTSS, PTSD, and women in relation to high-risk pregnancy. But I didn't think about trauma and men, or PTSS and PTSD within the fathers and the partners. And I think what you're highlighting is that we need to start looking to the fathers and what they are experiencing, with the pregnancy of their children. So it is, very under-researched area, and I think a very necessary area that we have to start engaging. I agree with you, Professor Wegner. It is really fascinating work looking at masculinities, hegemonic masculinities in relation to an area that is so female dominated. So thank you for that, Carl, and your timing was impeccable. Thank you.
Thank you. I really appreciate it.
Yeah, you're welcome. So we go on to Prof Suka, also from OT. I think the OT department is dominating our presentations today, but well done. Prof Suka is a professor and the current chairperson of the Department of Occupational Therapy at UWC. He has extensive experience in the area of vocational rehabilitation. He has published several articles and chapters in international peer-reviewed journals and books. Prof Suka has been awarded a C3 NRF rating in January 2021, and he's been called upon to be a keynote speaker at various international conferences. Welcome, Prof Suka, and over to you.
Thank you, Prof Andipatin. I'm going to just put off my camera because of connectivity.
Are you there, Prof Suka? I think we might have lost him. Melody, can you check quickly?
He's still there, Prof.
Okay.
Everybody can see that.
We don't have anything on the screen, Prof Suka.
I can hear you. Yes, I can. No. Internet. I'm just here.
There we go. We can see something now. Prof Suka, are you there?
Chair, Professor Suka is there, but I think his bandwidth is just really bad.
What would you like us to do?
Prof, we lost him right now. It's your call. I think we could possibly go on to the next speaker.
Yeah, let's go on to let's go on to Prof Saval, and then maybe if you could just inform him that we'll come back to him. Prof Saval, are you okay with that?
Good morning, everybody. I am indeed.
Okay, let's move on. Prof Saval is a professor in psychology, but currently the director for the Center for Interdisciplinary Studies of Children, Families and Societies at UWC. He obtained his PhD at university through the University of the Western Cape and Kent University, which was funded by the, I can't pronounce that those terms, but it's the Flemish University. His research interests include childhood studies, children's subjective well-being, child well-being indicators, child-centered research, and children's rights. Currently, he is the PI of the Children's World Studies. It's an international survey on children's well-being and the multinational qualitative study on children's well-being. He's also the lead member of the core international group conducting a multinational study on the impact of COVID on children's well-being. He's the founding and current board member of the South African Positive Psychological Association, a member of the National Child's Rights Intersectoral Coordinating Committee, and an executive board member of the International Society for Child Indicators. Welcome, Prof Saval, and over to you.
Thank you so much, Prof Andipatin. I just want to check if everybody can hear me. My apologies, I have a bit of a flu, so my voice is going to be out. I'm going to share my screen. Also, I have a new headset, so I'm just going to be asking if everybody can hear me clearly.
Yes, I can hear you.
I will commence. Okay, so just want to find out if my screen can be seen.
Yes, we can see your screen. Are you on slideshow?
I am trying to get there.
Okay.
Okay, here we go. So are you still seeing the screen? Let me just check, please.
Yes, that's all good.
Just click on from beginning, Prof.
From
To your
beginning.
left, yes.
Okay, so can I just check everybody can see the slideshow?
Yes, we can.
Okay, perfect. Thank you so much. Thank you, Prof Andipatin, and thanks to everybody for making this opportunity available. Let me apologize again for the poor quality of my voice, but we will proceed. I will start with acknowledging the faculty and the DVC for making this opportunities available. Also to acknowledge the Jacobs Foundation that funded this study and the International Society for Child Indicators. So I'm going to start this and commence this study by asking us to think about the SDGs and human development as it relates to one another. It's a very interesting article that's been published a year or two back by Deneuve in the journal Nature that looked at developing a SDG index score, which he plotted on the x-axis and the subjective well-being score using the World Happiness Data, also referred to as the Gallup report. And when you looked at and when you plotted those two data points against one another, we have some very interesting results that have emerged in relation to SDGs and human development. We can see that there is a definite relationship between those that score higher on the SDG index, which is a combination of all the SDGs, and the world happiness outputs. If you look very carefully, we'll see that the relationship is somewhat linear. So in other words, those that are scoring higher on the SDGs would invariably score higher on the subjective well-being or the happiness index. However, it is, or close analysis will show that this relationship is likely more quadratic. And by quadratic, it means that those that are scoring at the upper extremes of the subjective well-being scores and those that are scoring at the higher ends of the index shows a stronger correlation up to 0.79 between the SDGs and the subjective well-being. In other words, it is a very clear, definite relationship, especially for those that score high in both on both systems. And this is really, one looks at the traditional Nordic countries such as Finland, Denmark, Sweden, and so on. You'll see that there will be the countries that are scoring much higher than the rest. Of greater concern are the light blue scatter plot at the bottom left-hand side of the screen. And those are unfortunately the sub-Saharan African countries that are scoring lower in terms of the SDG index, but then also scoring lower in terms of subjective well-being. So that just shows that quite a bit of thought and energy has gone into trying to make sense as it relates to SDGs and its relationship to subjective well-being. So my presentation today, using that as a baseline, is looking at child well-being. And we commence the presentation with two questions. Why focus on well-being? And the second question is, what do we envisage for our children? So we know that the science is absolutely clear that higher levels of well-being leads to improved psychosocial outcomes, and that leads to improved quality of life. And this has been shown across all different contexts, using all different types of methodologies and indices, that this relationship is causal, and this relationship is both contextual and it is unanimous. But what do we envisage for our children? If we look at the second question, we want them to have decent objective standards of living. And by objective standards of living, I'm making a reference to our traditional well-being indicators. And these indicators are reflected even in the SDGs, as was mentioned previously, issues around infant mortality rate, under 5 mortality rate, immunizations, the level of nutrition, access to electricity and running water, educational indicators, and so on, all point to objective or quality of life standards of living. But certainly we want our children to have more than that. We don't only want them to be objectively well, we also want them to feel subjectively satisfied with their lives, and not just their overall lives, but also certain aspects of the lives across different multiple domains. So the argument is within both within the academic literature, but also more increasingly within the policy space, that we need to combine traditional objective indicators with indicators of subjective measures. So historically, children have been absent in social statistics, and this changed with the onset of children's rights legislation. It changed with epistemological shifts and theoretical shifts in theories on childhood, and certainly there was quite a strong impetus from the positive psychology and the positive social science movement that shifted the focus away from adult perspectives and shifted the agenda towards subjective perspectives and how children think and make sense of their lives. Now, while we have made considerable progress both at international and local level, at the national level in terms of measuring the state and well-being of our children, we know that those indicators that have been produced are mostly objective indicators. And the argument is that the objective indicators can only provide a partial understanding, but we also want to know what children think and what children feel about their lives. And if we have those two affective and cognitive components, which are critical to understanding subjective well-being, then we can have a more comprehensive picture of how children are doing. Our epistemological position is that children are a valid structural feature of society, that the perspectives are real, and that the perspectives are valid, and that they have the meaningful capacity to be able to reflect and make sense of their own lives. And this led to what is referred to as the child indicator movement, and ultimately advanced the research area of child-centered research. So today I'm going to be presenting the results on the Children's World Survey. And this survey started, initial discussions started in '96, then started in 2001. Further discussions happened in 2005, and eventually in 2009, we were able to secure seed funding from UNICEF to put together a project that looked at how children think and feel about their lives in general and certain aspects of their lives, but across multiple contexts and across different countries. So we looked at developing and collecting a representative data on children's lives and things such as the social relationships, the daily activities, their perceptions of safety and bullying, the school experiences, most importantly, children's rights, and then, of course, the perceptions and evaluations of their own well-being. So this project officially started in 2009, and it was funded by UNICEF and the Jacobs Foundation. We were fortunate enough to be involved in the project since inception, and we are now entering, or have now just completed, the fourth wave of data collection. The first wave took place in 2012, the second wave in 2014, the third wave in 2017 to 19, and the fourth wave, which includes 20 countries and just over 23,000 children, was in fact coordinated by UWC and took place during the COVID-19 pandemic. So this is what the sample looked like in the fourth wave of data collection. Perhaps this gives a better description. So we have sample size and percents of the sample. You'll see that South Africa is in blue there. We contributed 1,000 children between the ages of 10 and 12 years old. The biggest, or the country with the largest percentage is Belgium at just over 10.2%, Chile 7.1%, and Indonesia 9.3%. And we have a total of just over 23,800 children. We had participating countries were in the lower middle income bracket, upper middle, and then high income countries as well. So how we managed this, we had a core group that was the coordinating committee managed through UWC. We developed the instrument by constituting an expert committee, developed a draft instrument. That instrument went for peer review. Then it went for the core group also oversaw the sampling, the data collection protocols, which is of course very important in cross-cultural studies, as it allows cross-cultural analysis to have a level of invariance, and this will then allow us to make reasonable claims between the different scores between the two countries. So it was important that we had a committee that oversaw the sampling and the data collection process. We went through different rounds of adaptation, of piloting, and each country was required to conduct ethics clearance as it related to their own policies and procedures in the country. So this was a sort of a two-pronged approach, which was a core group that was overseeing the entire process, and then country teams that were conducting the adaptation and translation and the piloting within the specific countries. So I have some examples of some of the findings, and because we had over 300 items in this questionnaire, I distilled just a couple of questions that I thought that may be interesting, but also just to say this was the first time that we also conducted a parallel qualitative data collection process. So we have data on both quantitative and qualitative as it relates to children's perceptions of their lives during COVID, but with a specific emphasis on their well-being and happiness. So this is a very interesting table because this is the very popular overall happiness question. And the question is, thinking about your life before COVID or coronavirus, how happy are you with your life as a whole? And you can see the blue lines represent a mean score between 0 to 10, and the black lines represents the mean score between 0 to 10, but that was during the coronavirus. So the blue line is before coronavirus, and the black bar is really during coronavirus. And you can see across all countries, there was a substantial decrease in the sense of happiness during the period of the pandemic. Now, it's important to note that this the mean score between 0 to 10 has, in fact, some meaning within the child research space. Any scores between 80 to 90 are regarded as scores that can be expected, considering different issues around response bias and what can be expected if one uses a multinational sample. So it's broad range between 80 and 90. Anything below 70, from a theoretical perspective, we note that subjective well-being or happiness is held through a homeostatic process at a threshold of 70. Anything below 70, or on this scale will be 7, indicates that the threshold is breached and that the important issues that are controlling the children's lives are beyond their control. So in this case, it will be, if we look at South Africa, for example, that before the coronavirus, the scores, they would peg at 8.57, which is so right in the middle of what we would expect between 8 and 9. But during the coronavirus, it drops to 5.67. And because the 7 is the threshold score, there is a very clear indication here that the homeostatic threshold has been breached, and that children under homeostatic control has been lost, and that children are really under the control of the anxiety towards the pandemic. And this is really true across all countries. While there has been a stark drop in South Africa, there is perhaps less so, for example, in Romania. We'll have a score of 9.26 as opposed to a score of 7.7, and that shows that in Romania, for the Romanian children, homeostatic threshold is holding. Now, this question on happiness, the happiness level before and during COVID, really captures the affective component of subjective well-being, but there's also a cognitive component, as we present in the next screen. As you can see here, this looks at the cognitive component of life satisfaction captured for the 20 countries, and we use a scale referred to as the Children's World Subjective Wellbeing Scale. So the average there is 7.95, that's the green bar in the middle. And you can see that South Africa scores 7.79. So this was conducted during the pandemic. And prior to the pandemic, the mean score was 8.47. So you can see that in terms of cognitive well-being, with the cognitive component of well-being, there was a slight decrease. However, with the affective component, there was a substantial decrease. So as it relates to the cognitive component of cognitive life satisfaction, from a South African point of view, we can see that we are scoring reasonably in the middle of the distribution, not too far from the average, and also because it's above the 7 threshold. The idea is that homeostatic control is holding as it relates to the cognitive aspects, but not to, as I mentioned in the previous slide, as it relates to the affective component. Another interesting slide that I'm going to present is the satisfaction with learning at school. And we know that school has been affected substantially across all contexts. And I draw your results again. The yellow is before and the orange is during. And you can see that the score of 8 on a mean score of 8 before and a mean score of 6.7 during. And there is a substantial decrease for all countries from the before to the during part of the pandemic. So the issues here that are quite interesting is this is a collection of how children thought that the school lives have been affected. Importantly, it wasn't really a homogeneous experience. So the idea is that when one looked at these results in collaboration with the qualitative results, it is clear that, for example, some students in the rural areas would have experienced and have reported an idealized return to nature, an opportunity to spend time with their friends because schools were closed, an opportunity to reconnect with nature and to reconnect with the environment. And that led to a certain sense of happiness. But at the same time, because of the impact of the pandemic, not allowing them access to the school, the realization soon set in that actually that they were falling further behind with the schoolwork. So we know that the children are not a homogeneous group. We know that childhood was not a homogeneous experience. We also know that the experience of schooling and experience of the lives during lockdown was not a homogeneous experience. So children were vacillating between being really chuffed and satisfied at not having to go to school, and very soon thereafter realizing that they are falling further behind in their work, and that the immediate, medium, and long-term futures did not look that rosy any longer. And these were the types of tensions that we picked up in our discussions with children as well, how they were trying to manage the tension between being okay, being at home, but also having the sense and the realization that they were falling further and further behind. Another interesting slide was the relationship with friends before and during COVID. The blue line is before and the green line is during COVID. So there was a consistent experience and consistent sense of well-being and happiness before COVID. But as you can see, there was a substantial impact and much more vacillation between the scores across the countries during the pandemic. Interestingly, in the next slide, satisfaction relationships with people I lived with before and during COVID. So the people I lived with is really a synonym for my family, but just easier to translate into multiple contexts. And this one was very, very important because you can see there's a much closer relationship between the before and the during. And the interesting part about this analysis is that it shows when we conduct further multivariate analysis, is that children that have stronger relationships with the family, that report higher and or being closer to the family, showed higher levels of well-being and being less affected and less anxiety around the pandemic, which shows the strong mediating factor that that relationships with family had. So just a quick summary of the findings. We know that across all the different contexts, across all the countries, children's lives were profoundly affected by the COVID-19 pandemic. We know that children had to stay at home for many days in all contexts. There was 2 countries where children continued their schooling, but that did not have a substantial impact on the or create any outliers in the analysis of our results. But there was substantial variability across countries, and this is important because it's both in terms of school attendance, children's education, how they experience the education, but also as it relates to the access to technological devices. So the children were saying that regardless of the opportunities that were created, it was all dependent on access to devices, and to the extent that they were able to access the teachers during this period. The other issue that were, of course, affected was the variability around the country in terms of the amount of funds that were spent. And so we found that where countries invested more heavily in the education space, that these children reported higher levels of being able to cope with the schooling during the pandemic than those countries that did not.
Prof Saval, you have 1 minute left.
1 minute. I'll just another couple of interesting results. Okay, so I think the most important one for me was that the friends and the family was critical. While there was a decrease in scores from before to during the pandemic, as I mentioned earlier, those that were able to maintain good, strong relationships were those that were able to manage and report higher levels of well-being and lower levels of anxiety during the pandemic. Okay, so just a few broad messages. I think that the first one is that children's lives were affected in a number of different ways. But I think the most important message is that we don't understand the mechanisms, and we are not sure on what the long-term consequences are going to be. We therefore need to invest substantially in understanding how these mechanisms have affected children. I think we need to ditch the prefixes of before, during, and after, and understand that there's a shifting nature of how children have been affected, but it's also affected our issues around how we theorize. It's affected how we think about our methodologies, and it's certainly affected how we think about access to children and the role of children in society. I think I'm going to stop there. Prof Andipatin, I have 3 more messages, but I think that I've run my course. Thank you so much.
Yeah, thank Prof Saval. There are 2 questions in the chat. I wonder if the decrease in happiness during COVID-19 can be related to the strictness of the measures enforced by the government of the respective country. In Russia, the difference is very small, but there were strict measures only in the very beginning. They very quickly stopped wearing masks and paying attention to any safety measures. And then the second question is there any way to evaluate the COVID-19 effect on preschoolers?
So I will take the second question first. Yeah, so we're currently developing a schedule and in fact, it's going to be hosted in South Africa in February, on how to develop innovative methodologies to be able to engage with children at preschool level. This is in fact, what was mentioned preschool was children 5 and 6 years old. So there's quite a bit of use of emoticons. There is innovative qualitative methods that's being used, that's being developed. So probably next year, this time, I'll be able to report a little bit more on those advances. But certainly those are issues that have arose and that have been asked by other researchers around the world as well. So it's becoming very topical to work with young and younger children. As it relates to the first issue, I think the broad answer is this is what our results are showing us. So I won't discount the hypothesis put forward, but the results are showing that it depends on how the happiness depends directly on how the experience of COVID was managed through the family. And this obviously now depends on who the caregivers are, if there was a stable nuclear family, if there was good relationships between family members. Those that have higher levels of happiness are those that had stronger family relationships.
Yeah. Thank you. I mean, just the magnitude of the work that you're doing across multiple countries is really phenomenal. So well done, and thank you for a very good, informative presentation. Colleagues, we're now at the last presentation, Prof Suka. I have introduced him, so I'm going to hand over directly to you, Prof. You can continue. Prof Suka.
Can you hear me now? Apologies, can you hear me?
Yes, I can hear you. Okay.
Hopefully a second round will be better. I'm at the research site, so it's a little bit difficult to manage.
Okay.
Melody, thank you so much. So good day, ladies and gentlemen. The principal investigators of this project are Professor Lisa Wegner, as well as myself, Shade Suka. And the project focused on implementing and evaluating a program to promote resilience amongst out-of-school youth in Cape Town. You can go to the next slide, Melanie. So ladies and gentlemen, in this slide, I want to provide some context related to the SGD Goal 3 and Goal 4. If we look at a typical European country such as France, with a similar total number of population to South Africa, we can see that both countries spend a similar amount of their GDP on education. France spends 5.4% of GDP on education and South Africa spends 6.2%. However, if we use education as a basic indicator of work skills development and ultimately employment, then we can see that we have some challenges in South Africa, as the unemployment in France is currently at 7.4%, and in South Africa, it is at 33.9%. So we may have to think differently about education and how this could influence work skills development and employment. Can we move to the next slide, please? So ladies and gentlemen, the National Developmental Plan in South Africa highlights the need for enhancing service programs for youth, especially if the focus is on enhancing the skills of youth to enable them to be productive members of society. Statistics reveal that 17% of 16-year-old individuals are out of school and 32% falls into a category known as NEETs. And that's an acronym for youth who are not educated, employed, or trained. Can you move to the next slide, please? Many youth in the Western Cape are at risk of not completing school, and many of these individuals may use substances due to a lack of participating in healthy occupations. Can you move to the next slide? Ladies and gentlemen, the current contribution of this project was to evaluate the usefulness of a youth-related program that used positive youth development principles, such as building competency, related life skills, and enhancing their confidence. Finally, the program also used principles related to enhancing work-related skills as advocated by the model of occupational self-efficacy developed by Suka and colleagues. Can move to the next slide. Research has proved that client-centered approaches are needed in order to build acceptance by consumers of a specific intervention. And in this study, having youth identify their own needs and also be involved in development of the program was deemed as important. So we can move to the next slide. The research question of the study was therefore, what is the usefulness and value of a positive youth development program that broadly aims to build resilience and reduce risk in out-of-school youth in Cape Town? And this question was followed by two objectives, namely, to explore and describe the youth's perceptions of the usefulness and value of the program, and objective two, to explore and describe the enablers and barriers that influence youth's attendance and involvement in the program. Can we move to the next slide? The study used a qualitative descriptive research design specifically using intervention mapping. The study used semi-structured interviews in order to collect the data. Purpose of sampling and a set of inclusion and exclusion criteria was used to select study participants. We can go to the next slide. Melanie, we can go to the next slide. Thank you. The study used thematic analysis in order to analyze the study findings. We can move to the next slide. And trustworthiness was used in order to assess the quality of the study, specifically utilizing the methods described by Crafting. And we can move to the next slide. All ethics-related procedures was adhered to. And on this particular point, I must indicate that because of the age category that youth falls into, we still require that some individuals double check whether they actually wanted to be involved in the study and that they were not coerced, especially because we marketed or the study via the schools. You can move to the next slide. So ladies and gentlemen, the model of occupational self-efficacy is a 4-stage model that focuses on enhancing a client's self-acceptance of their circumstances and facilitates goal development through a process called introspection. In the last 2 stages of the model, there is a specific focus on enhancing work skills of the youth by means of role play and work test placement. So what that actually means is that we actually get an individual to engage in work-related tasks. So if it's somebody that wants to engage in carpentry or sewing, that they actually do that work for a period of time. We call it simulated task assessments. And then from there, they actually work in a real life or work type of setting, doing that type of work to give them the actual real life experience. Can move to the next slide, please. Ladies and gentlemen, the intervention used in the study focused on 8 sessions. That was 2 hours in duration. The intervention focused on the client's self-acceptance of their circumstances, improving their work skills, communication skills, budgeting skills, stress management skills, and ultimately a reflection on their own performance. Can move to the next slide. The participants in the study were selected from 2 communities, namely youth in the Bellville South, as well as for Santa Cruz. And the age of the participants ranged from 15 to 32 years of age. Can move to the next slide. 2 themes emerged from the study, namely barriers and facilitators related to the implementation of this program. Can move to the next slide. Theme 1, known as COVID lockdown, prevented participation in the program. So this program, ladies and gentlemen, was initiated in February and March 2020, just when the lockdown hit us. And this caused considerable challenges to the implementation of the program. So one specific barrier related to the long period of time between the pre-COVID and post-COVID related period. So what basically happened is that we had a program that we had to actually adjust and adapt after the lockdown period, because we still wanted to have some form of input from participants about the program. And this caused a little bit of issue in that a lot of the original content of the original program we could not implement in the second or adapted version of the program. And this caused participants not to implement skills learned in the program, specifically implementing the skills in real life settings. Furthermore, due to the COVID pandemic, the time period of intervention had to be adjusted once the COVID restrictions were lifted. Most topics, such as the focus on leisure activities, managing family responsibilities, and work, could not be covered in detail. Can you move to the next slide? Theme 2, known as positive factors related to the usefulness of the program, described the enablers used in the current study. Some of the enablers or positive aspects of the program included learning about topics that enable the youth to know themselves better, as well as improving their life skills with the emphasis on enhancing their communication skills and coping skills. Can move on to the next slide. Finally, the study participants felt that the program enabled them to identify resources in the community that would enable them to identify healthy leisure activities such as sport or crafts as a substitute for negative recreational activities such as illegal substance use. Can we move on to the next slide? So the findings of the study in conclusion, ladies and gentlemen, presented some of the barriers and enablers relating to the operationalization of a youth program. The study also highlighted that in order to be therapeutic, the treating health professional needs to partner with community organizations who are already working with youth, as well as partner with youth in order to ensure the effectiveness of a youth skills development program. Because if in our experience, if you are developing a program and within your second or your third session of the program, you'll find that, you know, the content of the program is not being seen as favorable, then during that stage, you should actually try to adapt the program, because we found that you need to use a kind of an iterative type of flexible approach in order to get youth to engage in contents of these type of programs. Can we move on to the next slide? So the study was sponsored by the Cape Higher Education Consortium, as well as the City of Cape Town. And move to the next slide. If you would like any information pertaining to statistics related to the number of participants and the results of the study more in detail, you can contact myself, msuka@uwc.ac.za, or Prof Wegner at lwegner@uwc.ac.za. Thank you so much, colleagues.
Thank you, Prof Suka. Wow, colleagues, I think we've really had a treat this morning with all our presenters showcasing the work that they're doing within our faculty. And I just posted on our Manco group what good presentations we've had this morning. So I'd like to take this opportunity to thank all our presenters, our panelists, the attendees for participating. Thank you to IA, thank you Melody, thank you to Maxine and everybody from the DVC's office that made this possible. I think it's really been good in terms of showcasing how our work aligns to the SDGs and the work that we're doing in our faculty, how it aligns to the university's vision and mission for research. So thank you so much, everybody, and enjoy the rest of your day. Melody, are you there?
Yes, Professor, we are just showing the next session's information.
Okay. Thank you so much. Thanks for organizing everything.
Thank you, Prof.
Bye-bye.